My name is Samia Mora. I'm a cardiologist at the Brigham and Women's Hospital in Boston, Massachusetts. I'm also an associate professor at Harvard Medical School and the director of the Center for Lipid Metabolomics at the Brigham and Women's Hospital. My talk today at the 21st World Congress on Heart Disease in Boston, Massachusetts was on secondary prevention strategies in patients who've had prior cardiovascular disease. So the first thing to note in patients who've had prior myocardial infarction, heart attack, or stroke, or other vascular disease is that their event rates for having a second cardiovascular events are quite high. In fact, about 1 in 5 patients will have a cardiovascular event over a period of about 5 years in the studies that have looked at this. So these event rates could be higher or lower depending on a patient's risk factors, such as whether or not they have high blood pressure, diabetes, high body mass index, etc. Now, there are many emerging ways to target this risk, to reduce the risk of these events. Some have already very commonly used and standard of therapy, such as aspirin, statins, beta blockers, ACE inhibitors, and angiotensin receptor blockers. But there are many other new and emerging aspects of reducing risk, and we discussed several of these. The first one involves thrombosis, so the clotting system, and also how platelets are involved in thrombosis. Of course, aspirin is the mainstay of therapy there, but dual antiplatelet therapy, so adding an ADP receptor antagonist on top of the aspirin can reduce risk of thrombosis or clot formation. However, it can also increase risk of bleeding, and that's really the tension there for mechanisms that target thrombosis or clots. There are very new agents that are being tested in this pathway. What we do know is that in patients who are at high risk for cardiovascular events and are at relatively lower risk of bleeding, that they would potentially benefit from having more aggressive antiplatelet or anticoagulant therapies. Another pathway relates to lipids. So here there are many emerging therapies, and we know statins are the mainstay, but there are newer therapies that target, for example, the PCSK9 pathway. These are antibodies that are directed against a component of the LDL receptor, and by inhibiting that pathway, there is more uptake of cholesterol and other atherogenic lipoproteins from the body. Preliminary studies suggest that these really reduce LDL cholesterol and other atherogenic lipoproteins substantially by about 50 or 60% for LDL cholesterol. And they are being tested in large clinical trials for reducing cardiovascular outcomes. So those will be awaiting several of those agents and their results coming out in the next few years. Another pathway of residual risk involves LPA, lipoprotein little a, which is a molecule that has a lot of cholesterol, but it also has potentially a pro-clotting effects. And this one is being targeted in also some of the newer therapies by about 20 to 30%. Of note, statins do not reduce LP little a. However, statins reduce the increased risk associated in patients who have high LPA. This one is important to consider if patient has had recurrent cardiovascular event. Then often these may be elevated, and newer, more targeted molecules that target specifically the ApoA component of LPA are actually show huge reductions in LPA, such as 80 or 90% reductions, almost really low, very low levels of LPA seen in patients with that. But these are being tested right now, so we don't know yet the answer of whether or not these will benefit patients. Now, another aspect that's been really recently recognized is also medications that relate to glucose lowering. For example, there are 2 studies that have been published in the past year that are really dramatically lowering cardiovascular events, in particular cardiovascular death and even all-cause death. In both studies also they showed reductions in heart failure hospitalization. And these agents relate to glucose metabolism, but they also have other effects. The first one is from the MPEG reg outcomes trial, and this one is an SGLT2 inhibitor. So this is an inhibitor of the glucose, sodium glucose transporter, where we excrete a lot of our glucose in the kidneys. And this agent that was tested about a year ago in the MPEG outcomes trial, it really showed huge reduction in cardiovascular and all-cause death by more than 30 or 35% with relative risk reduction, and about a 15% reduction in cardiovascular events. So really very promising agent, but it also has other effects such as reduces the weight by a few kilograms, reduces the blood pressure, both the top and the bottom numbers, and also has other effects on volume by getting rid of fluid. So we don't really know what's the exact mechanism that's really benefiting, but very interesting agent. And the other medication that was also recently tested, actually just last month, the study came out in the New England Journal. The study was called the LEADER trial, and this one tested the GLP-1 agonist. So this is another agent that targets glucose metabolism by enhancing insulin sensitivity. And this agent actually also showed a pretty impressive reduction, about 15% in cardiovascular events, and also about 15 or 20% reduction in cardiovascular and all-cause death as well. So again, very promising agents. Look forward to seeing more of their effects in the near future. Another pathway is also relating to inflammation. Inflammation is has many different aspects, and there's upstream pathways that we can target to reduce inflammation, and those are being tested in several trials, including colchicine, which is an anti-gout medication, is being tested for cardiovascular benefit, and two studies from our division, the CERT trial and the CANTOS trials, that are testing, the first one testing methotrexate, which reduces inflammation, and the other one, CANTOS, testing canakinumab, which is an IL-1 receptor blocker. And this one, the results should be coming out also in the next year or so. And then finally, there's clinical factors, such as we can reduce risk by encouraging physical activity and referring patients to cardiac rehab, which is completely underutilized. Still only about 2/3 of patients who should be referred to cardiac rehab get referred. And of those who do get referred, only 1/3 of them show up to the cardiac rehab. So there's really a lot to do there, because that has been shown to reduce mortality from cardiovascular disease and even all-cause mortality by about 20 to 25%. So really class 1 indication. Other aspects that are very important are the dietary types. So the Mediterranean trial, a Mediterranean diet in particular, has been shown to reduce death, including sudden death and cardiovascular events, as well as other outcomes, has benefits towards reducing diabetes and even cognitive decline with aging. So Mediterranean type diet is now recommended for cardiovascular prevention. And then finally, encouraging patients to take their medications and ways that we can make it more cost effective. So by reducing copay, a few years ago, a recent study was the MI-free trial, which showed that if patients even got their small copay taken care of, they were improved their compliance, improved their adherence with taking the evidence-based therapies, and actually improved their cardiovascular event rate. So they had lower heart attacks, and whether fatal or non-fatal, during follow-up. So again, these are all different aspects, a multifaceted aspect to cardiovascular prevention, patients who've had cardiovascular events. And that is really key, because these patients, again, are at high risk of cardiovascular events. About 1 in 5 will have an event over the next 5 years. So really important to target it from different aspects so that we can reduce their risk.